Start recording. There we go. Okay, so welcome to today's discussion. We have as our discussion leader is Regina Butler. Has been in nursing for over 26 years, and she has a lot of experience. Some of that experience is she's medical, surgical, and telemetry, home health nursing, nursing educator, and emergency room. After earning her Master's of Science in Nursing Administration in 2017, Ms. Butler accepted the position of Director of Patient Care Services at a small yet challenging hospital in Newport Beach, California. Ms. Butler considers herself an advocate for her patients in her care. She decided to return to school, and in 2019, she graduated with her postgraduate certificate from Charles Drew University Nurse Practitioner Program. On a personal note, Regina is the oldest of 7, mother of 1 son, and likes walking in the park and watching murder mysteries. So at this time, I'm going to turn it over into the hands of Regina Butler.
Hey everybody, so thankful that you guys invited me today for this very important discussion. I started to put into my personal blog, I'm the most prettiest sister and most smartest one as well, but I didn't want to make Lisa mad. But we're going to go ahead and get started to be timely in our discussion today. Again, thank you for inviting me. So what I'm going to do is try to pull up my PowerPoint. Let's see if I can get it to go to. Can everybody see the PowerPoint? Okay. Okay, so our topic of discussion today is COVID-19 and communities of color disproportionate disease. And there's my name at the bottom there, okay? So we're gonna go ahead and get right into it. Try to decrease this so that I can see the whole entire screen. Systemic health and social inequities. So this is not a new subject to me. As Lisa alluded to, I was an ER nurse for 15 years in the middle of what we call the hood, South Central LA, in Los Angeles, California, and Watts. And, but this has been longstanding in our society, systemic health and social inequities. And it has put some of the members in our society at an increased risk for getting COVID-19 and experiencing severe illness regardless of their age. And as you see on this PowerPoint, it just gives a little information about, you know, racial and ethnic minority groups, including the non-Hispanic Blacks, Hispanics and Latinos, and your American Indians, have the higher rates of hospitalization or death from COVID-19. Now, and we're gonna talk about a little bit about, you know, why in just a minute. But, and you will see, you know, the correlation to both. But basically, you know, when I was in nurse practitioner school, we would have questions, who has the greatest prevalence and incidence of this disease process? And the answer was always African American. So everybody always got the answer correct. We usually have these comorbidities that cause us to be at risk for these disease processes that we don't need and don't want. So why? So again, due to comorbidities, in healthcare, I think that, you know, going back, and we'll see a little bit about past and future, past and present, but I remember, you know, my grandmother always went to the same doctor, you know, and whatever that doctor told them was word, you know, what they believed it. They were the little GODs of healthcare. So some of our comorbidities that you guys are going to recognize is I have diabetes. Diabetes is a killer amongst our society in large. But for African Americans and other minorities, it is definitely a killer. And I'm very overweight. This is one of my side passions, is obesity, you know, trying to decrease the prevalence and incidence in my own family about obesity, because being overweight increases your opportunity to get other things, and for diabetes, for heart disease, and other things. So one of the things that we can work on really, really quickly is losing weight. You know, losing weight would decrease your prevalence and incidence of getting diseases such as COVID-19. Being in a more healthier state will decrease your prevalence and incidence. Stroke, heart disease. A lot of African Americans, Hispanics have an increased prevalence and incidence for heart disease and stroke. And then STIs, or sexually transmitted infections. So you would not believe the number of young people that come into the clinic or come into the ER with as much education as there is out there about this, and be positive for STIs. So again, you are now risking yourself because of not adhering to the education that's out there to these deadly diseases. And what usually happens is we wait to the last minute to make sure that we're okay, or something will happen to trigger you to go to the ER or go to a clinic. And that's when you found out, if you only would have came a little sooner. So it's wreaking havoc in our society and in our smaller communities, and our African American Hispanic communities. So root cause of health inequity. So literature identifies two main clusters of root causes of health inequity: intrapersonal, interpersonal, interstitial, and systemic mechanisms that organize the distribution of power and resources differently across the lines of race, gender, class, sexual orientation, and gender expression. So, you know, we see that, you know, institution, what are we talking about? Government, right? We're talking about up here. We're talking about education, things that we really, as, you know, African Americans, Hispanics, and minorities are trying to get to. We're trying to get to, but it's unequal. And so this you know, identifies with the root cause of why there's an inequity in healthcare. One of the main things is knowledge, and we'll get into that in just a little bit in power. Number two, the unequal allocation of power and resources, including goods, services, society attention. Now what's going on is we are having a lot more attention to this situation that's going on in the whole wide world, right? We have the whole wide world looking because it's affecting everyone, okay? But before this, I remember doing a paper in my master's program on disparities of healthcare. And it was just a paper that they had you do for everybody. And it wasn't a big deal. It was just like, oh, this is how it is. This is how it has been. And nobody was really paying close attention or doing anything about it. So this manifests in unequal socio-economic, environmental conditions that causes the social determinants of health. We know that African Americans and other minorities don't have the access to healthcare that they need. And when they are presented with it, in my experience, they do not utilize it because of the education. They don't have the education. Again, going back to my grandmother, you know, who had the same doctor, refused to go anywhere else. That's just who you had. And, you know, you didn't want to veer from that doctor. And we also see in our neighborhoods, we don't have what you would say, you know, as many things that would promote health. We have a lot of liquor stores and a lot of weed stores, and the guy on the corner, you know, doing something that's shady, but we don't have the people that we need in our areas of concern promoting healthcare. And I think that's a huge discrepancy. We need for people to come back to those communities and help those people of color that don't have the education that they need, and teach them about health inequity and give them some other solutions that will help them. So historians and economics have attempted to calculate the amount of wealth transmitted from one generation to the next. And this is what they found. Baseline inequities contribute to intergenerational transfers of disadvantage and advantage for African Americans and whites. The inequities also reproduce the conditions in which disparities develop. What do I mean by that? Well, what I mean is that if you're already dealing with a situation where you grow up in a certain situation and that's all that you know, and that's all that your parents know, and that's all that your grandparents know, that's transferred to you now, into that generation. Until we break that generational curse, it's going to continue to be the same disadvantage. Okay, we have to start reaching back again and saying, no, we need to break that. We did do that. We were on that track, but now we're going to be on a different track of healthcare. We're going to make sure we get ourselves healthy. We're going to have the access to healthcare. We need people to lobby for that, but we need people in our own communities to lobby for that, so that we won't depend on others to do that. We've been dependent on others to do that for too many years, and it just has not happened, as we've seen lately in the recent uproars and demonstrations and the pandemic that is happening in our country. Wealth, power, and knowledge. So the reason why I put the word wealth first is because if you have wealth, you can buy power, okay? Donald Trump did it, okay? So if you have wealth, you can buy power. If you have wealth, you can buy knowledge, meaning that you can get somebody that, that say, hey, you're the one that got all A's and everything like that. I need you on my team. With wealth, you have them both. You have all three of them: wealth, power, and knowledge. There's a lot of people in our society, in our communities, that have the knowledge, but no support, no money. So what can you do if you have this great ideal and you want to open up a clinic and help people, but you don't have the credit, you don't have the money, right? What good is that without the other? So we have to start getting the person with the wealth, getting the person with the knowledge, getting the person with the, let's all come together and create better health care so we can decrease these disparities amongst people of color. Okay, implicit bias. So this is a word that I have known about for years. I just didn't know what it actually meant or what it actually was. Again, working in the ER for 15 years, I've seen a lot of racism and I've seen a lot of implicit bias, okay? Didn't know what it was until I did this little research. So this is defined as, one person defines this as a mechanism of unconscious discrimination, as a form of racial or other bias that operates beneath the level of consciousness. We don't know that we're doing it. So when I seen this, I said, if you can't say amen, you gotta say ouch, okay? Because I have done this myself, but I've seen plenty of providers doing this as well. The effects are greatest in situations marked by ambiguity, stress, and time constraints. When you come into the clinic that I worked at to get my clinical hours, it was a first come, first served basis. And it was right in the middle of the hood. It was dirty. The bathroom never worked, but they were used to that. So they still came. When I came in the morning, it was a line of people waiting to get in, first come, first serve. But the ambiguity, the doctor didn't really get to know these patients. It was just number 1, 2, 3, 4, 5. And I look at their chart and yeah, they've been here before, and I go on. The stress of volume of, the providers nowadays, the reimbursement is different. So they have to see, 40, 50 patients a day. So the stress of getting that volume of the stress of healthcare alone, which is highly regulated, and then time constraints. There's only 8 hours in a day for the clinics. And in an emergency room, again, you have patients that come in that may not be a true, what we call emergency, but you still have to see them all. And so you bump into all of this out there in the healthcare world. Literature indicates the implicit biases of healthcare providers is systematically worse for African-American patients than for white patients. Again, you know, I can tell you stories of things that I've seen in the emergency room. When I first started working there were like 3 African-American doctors and the rest were of different races. But before I started working there, everybody was, you know, predominantly Caucasian doctors. And there was a doctor there that was there for like 30, 40 years. And he practiced like he was 30, 40 years ago. So when you came in and you were in pain, he felt like, you know, why did you come into the emergency room for that? I'm not giving you no medication. And if it wasn't for nurses advocating on the behalf of patients, I mean, it would really be crazy how some patients wouldn't get treated at all. They just sit there in that chair in the emergency room for hours with nothing getting done because the doctor feels like, you know, they can wait. They can wait. You know, they're used to that. They're used to that. I've also seen the same doctor treat Caucasians differently, you know, that come in, say for instance, on a car accident, passing by on the 105 and just happen to be in that area, and they come in as a trauma, they get treated very differently, very differently. So implicit bias is very serious, and it can be not only for healthcare, but in our daily careers, okay? In our daily, what we're doing is people come in or you see students or whatever, and you're like, you know, automatically you form some type of, in your mind of how this person is, and you subconsciously do that. The evidence is clear that unconscious racialism perceptions contribute to differences in how healthcare providers perceive others and treat them. They did an experiment and did an MRI of some of the doctors, and they found that white providers hold implicit biases against African Americans. And some minorities providers may also hold these biases. Again, we're seeing, if you looked at the little video that I also had put up, African Americans, you know, providers, again, when you get educated and you start seeing other things up here, you know, your perception sometimes kind of go down when you're looking at other people, because you're like, well, why couldn't they do what I did? You know, I did it, you know. So, but we have to remember that we have to remain objective in healthcare and give everybody the same treatment if we can, but we're only human. Okay, so I just let that sink in, and that was more to me than anybody else, because I am guilty of having done this, have been a nurse for so long, and I said, wow, I'm going to really try to pay attention to how I react to patients that are in my care, because I do want to give them the best care that I can. Okay, here's my summary, but before I do this summary, I do want to tell a little story that I had told Lisa. When I became a nurse practitioner student and went to this clinic I was telling you about that was dirty and shabby and broke down, and the patients were there every morning before the provider was there. They loved Dr. Jack, and but I said to myself, I'm going to go in here and I'm going to educate these patients. I'm going to give it my best shot. And I had a lady who had like 20 different medications, and she was on the same medication. She was on 2 and 3 beta blockers, 2 and 3 calcium channel blockers, you know, on the same type of medications. And I told her, she was with a caregiver, you know, can I help you to determine what medications you should be on? Because you're on the same medications. You're going from doctor to doctor to doctor, and they're giving you different things. You shouldn't be taking all these medications. And guess what she told me? She just screamed, I want to see Dr. Jack. I don't want to see no student. You know, it's hard to penetrate the mind that does not want to change, the mind that does not want the education, but we still have to give it to them. We still have to give it to them, even though Dr. Jack said, see what I told you? They don't want to change, you know, and Dr. Jack would give them what they wanted. If they wanted Norcos, he would give them Norcos, you know. But I would always be asking, well, are you in pain? Why are you still on Norcos for like the last 2 years? But it's very important to still try. We still need to put that foot forward and say that we did try to offer other opportunities instead of just the same thing that you've been doing, especially if it's better for you. So in summary, this is health inequities are systematic differences in the opportunity groups have to achieve optimal health. It's a block, it's a barrier to get the best health. When you go to, and many of you probably can attest to this, I've worked at hospitals in the hood and I've worked at hospitals in Orange County. Now inside the hospital, as far as nurses go, we still doing the same thing, but I'm talking about the whole look of it. It's upper class. They want to attract people. On the lower class portion, they feel like you're used to it and you're going to come anyway because this is all you have in your area. So we need to do better as leaders and make sure that the people that are in our care, the people that depend on us, have better. That's the only way we can do it. And then we will get better subsequently in the people in our generation, right? We want our children's children to have better than the opportunities that we've had. So this leads to unfair and avoidable healthcare outcomes. So it is my opinion that we as a people direct our energy and fight for social and medical equality. This time, the time is now for us to create a powerful legacy for future generations. And I think that was, yes, my last slide. So I'm going to come out of here. I'm stopping the share. And I think we have discussion questions. Or does anybody have any questions, first of all, on the presentation?
Can we all clap first?
Thank you, thank you. Any questions on what was the PowerPoint or anything, and we can go right into the discussion questions. And I think Rachel said the discussion questions were already here somewhere.
So I have the discussion
Okay.
questions in front of me.
Okay.
So I'll read off the first one. The first question, and many of you may already have these in front of you. Why do we as Americans allow such health disparities to continue?
Am I allowed to speak as someone who grew up on the other side of the planet? So I've seen the differences in healthcare. Well, first of all, Regina, thank you so much for your work in the medical field, but also for giving these presentations and prompting us to think about these issues. So having experienced these two very different healthcare systems, I think that the biggest difference is how aggressively healthcare is monetized in the United States. It's not just more expensive. It's not just about the price tag. It's about why we made it so expensive, right? And so there's all of these structures, and you know, when Regina was talking about systemic issues, if you could compare it to educational inequity, to food deserts out there. You could think about redlining in real estate. All of these systemic issues that try to monetize difference, to basically make an extra buck from who's doing better than the next person, for who can afford better than the next person. And this is inherent in sort of a rampant and blind capitalism of the kind we have here. But it's the biggest difference, because when you go to a doctor in Bulgaria, where I'm from, and I swear an MRI takes about, a friend of mine was hit by a car in New York City and was told that the MRI is going to develop, meaning they're going to have MRI results in 2 weeks. And I called my mom, who works at a hospital in Bulgaria, and I said, wait a minute, how long does it take to get an MRI result? And she said about 8 minutes. So that differential of 2 weeks, what is that for? That's the monetizable differential. Because of course, if you went to a better hospital, it would take shorter. If you had more money, it would take shorter. And this is, you monetize that time, but that time is essential when we talk about healthcare. So I think, it's really hard to tackle, but I think at the bottom of it, it does have, and thank you for, mentioning money before, wealth before knowledge and power, because in the healthcare system, it does come down to money. And it's really disgraceful, because care has an ethical implication that goes beyond material means, or at least it should.
I agree with you. I don't want to take up the whole discussion. I want other people to be in on it, but let me tell you, the place where I work at, which is an awesome place, I love working there, but they already, when we had our outbreak, they started saying, how can we get money for this? And they already have a COVID ICD-10 code. And if you notice in New York, if you've been following along, when they had their worst thing going on, all the death certificates were COVID-19 first diagnosis COVID-19, because they're getting an extra $15,000 for that COVID-19 diagnosis. It just it's like, it's sad, and it just doesn't make sense, but that's what's happening.
I wanted to share, before I go into the second question, the first question about why do we as Americans allow such health disparities to continue? I honestly think that, again, going back to something you said about education, and even though I feel that, we grew up with medical care in our family. In fact, I still go to the same medical provider that we grew up with. And I remember being unemployed and being on welfare and having to go to a clinic. And I didn't have very many choices. And the clinic that I was going to was not too far from where I lived, but it was what I thought. It was clean, but of course, the treatment that I received, I thought it was adequate treatment, but again, the quantity and the quick look at you, and I remember even being fussed at by one of the doctors because him not understanding that I grew up with medical care. I've always had my health insurance, and then having to come to a clinic was very hard for me. And so I got this really big lecture from this doctor telling me that I need this and I need that and I need this. And when I left there, I felt worse than when I went in. So I think a lot of it is education and not knowing that. And what I eventually did was saying, you know what, I might have welfare, but I don't have to stay at this clinic. And because I have a little bit more education than maybe the normal person on, that I can go somewhere else. That's exactly what I did, because I figured whether I'm getting health care through my work, my job, or if the county's paying for it, they're getting paid to see me. And so I went somewhere else and took my little sticker and said, you know what, I'm going to go somewhere where someone's actually going to treat me and hear me out and prescribe something that I actually need and not what they think I need. So with that said, does anyone else want to comment on that first question? If not, we'll move on to the second. Okay. The second question is, healthcare disparities have existed amongst African Americans, Latinos, and other minorities for generations. What experience, if any, have you or your family member had with such healthcare disparities? And I know Rostin kind of shared a little too. Anyone else want to share on that?
Lisa, I will share that before I was a nurse, I went to a big prominent hospital and I had strep throat. And they told me when I went to this hospital that why didn't I go to county? And I didn't know about EMTALA violations at the time. I sobbed. I sobbed. I felt humiliated. I didn't have insurance. And that's why when I became a nurse, I said I would never treat anybody that way. When patients ask me right now, how can they pay for something? I say, I don't care how you pay for it. I don't cover that. My job is to take care of you. But it is humiliating when they tell you, why did you come to this hospital and not go to Big General? But you're right down the street from me. So it is a humiliating experience. But that was years ago before I was educated about an EMTALA violation. They can't say that to you. That's a $50,000 fine.
Anyone else want to say anything on that particular question? Okay, I'm going to move to the third question. Are healthcare disparities a new type of racism?
Well, I doubt if it's new. Regina, I really loved your presentation. Thank you so much for joining us here. It's nice to meet you, even if it's this remote way. But you know, what I was thinking about was how many effects healthcare have that people don't anticipate, or I wouldn't have anticipated. Everything's so connected. And I was thinking a little bit about Manning Marable. Some of you might know his work. He was an African-American Studies faculty member at Columbia for years. And he had a syndicated column called Along the Color Line. And I still remember one column that I read of his years ago, where he was talking about providing access to and a platform for success for Black students in higher education. And one of his remarks was so startling to me. He said, do you want to help Black students succeed at the university? Start with high quality access, or access to high quality prenatal care. And really that kind of blew my mind, you know, that it connected two dots that I wouldn't have connected in my mind, because I'm a privileged white person and haven't had to think about some of these issues. But it was a stunning remark for me to read.
Anyone else want to speak to that or have something to share? Okay, I'm just going to share on that one myself about, as Ruben said, I don't think it's new at all. When I hear stories again about our grandparents coming up and some of the things that they were not able, the medical care especially, that they were not able to receive, as far as even when having children, having children at home. And I even know a few people that attend my church who, due to lack of education and have never received did not receive prenatal care while pregnant, and even not even making it to the hospital to deliver. So I think in the sense of when we say racism, I think a lot of the disparity comes again with the education, the lack of education. Anytime we can have our youth being educated about condoms and birth control, I think that they can also be educated on getting good health care in general, and not just keeping it to preventive measures, but how to prevent, how to eat better so that you're not becoming a youth diabetic, or how to get up and exercise, and do various things to prevent some things that are known, as Gina said, some known killers in the African American community. You know, my family, my dad loves salt, hot sauce, so do I. But I learned that that's a killer, you know, and my grandmother passed away because of hypertension and some things to do with it. My dad because of diabetes. And so these are all learning areas that I try to even educate my children, even down to dental. You need your teeth, and not to be afraid to go to the dentist. But we've grown up without this being taught in a lot of our homes, being taught in the educational system in low income areas. And so we have people, I worked in the dental office, who the kids are afraid to be seen by a doctor. And I think it really goes back to education. I don't know if it's a type of racism, but there's something that needs to be done to, I think, do better at educating and saying you deserve to have good teeth, you deserve to have a good health. All right, moving on to the next question, and this is our final and our last question. Should African American healthcare providers do more to persuade and educate African Americans and other minorities about medical racism, or is it up to the individual to do the work themselves? Any silent partners out there wanting to share, jump in.
Lisa, you know I'm not a silent partner of any sort, but I'm dying to share here, and I've been looking at this question, you know, for a couple of days now. So first of all, I would say all healthcare professionals should be instructed to communicate, to explicitly communicate the issues of implicit bias that exist within the system. And the more people we have to do this, the easier it will be for anyone that is underprivileged. And I have two quick stories to tell. I was at Harvard Hospital, the research hospital at Harvard, about probably 15 years ago. I was a graduate student, didn't have a health insurance, and went there because I suspect that I had had a concussion in a bicycle accident. I was asked 10 times the same question. Was there any violence, interpersonal violence occurring? This is a question that, of course, you ask an immigrant that speaks with an accent and doesn't have a health insurance. I felt belittled by the assumption that it had something to do with violence, with interpersonal violence. But the other story is of an African-American friend of mine who was biking at 2 o'clock in the morning and was the victim of a hit and run. And so she lost some of her teeth, she broke her rib, and she goes to the ER, and the doctor immediately asked her, what did you do to him to get so roughed up in this way? So the doctor assumed that she had been the victim of domestic abuse, but also that she had deserved it, which is appalling. And is, again, you might have legal recourse in that kind of, in her situation, for sure you do. But guess what? She doesn't have enough money to throw a lawsuit at that hospital, right? So she just has to swallow that, you know, the psychological pain now that adds to the physical pain. So I think that all healthcare professionals should be instructed explicitly and required to speak about these biases, not just be aware of them, but speak about the bias, implicit and explicit bias, with the patient. And you know, there's all these consent forms. Add it to the consent form. Actually have it, the first line, which is, I belong to a vulnerable, you know, constituency, or I suspect that I could be treated differently because of the constituency I belong to, and therefore I require, you know, that conversation.
I'm just going to say I love that, because I tend to feel that automatically, you know, as my sister said, that our family battles with weight. But there are times when I go in for something other than that, but it's always reflected back at me, is my weight. If I have my finger hurts, it's because of my weight. And so I think there's a I don't know, I don't want to say disadvantage, but I think that healthcare providers should help educate, and I prefer a doctor. I'm just going to share. I recently was suffering from some bites, and the healthcare provider that actually met with me was very good. I mean, he actually even followed up with me the next day. I loved it. I felt like he actually genuinely cared about the reaction that I had to these bites. I think if we had some more follow-up that went on with our healthcare providers, but I'm also going to say, because I'm hearing in the voice of my mother, that we also have to look out for ourselves, and we have to start educating ourselves, and we also have to stop saying we have to stop waiting for someone else to do it for us. This is a different story than what Rawson's telling, but for those who are in the minority, who is the minority, and you're going in, you have to know the questions to ask, or you need to be able to talk directly to a doctor and let them know, I already know what I'm dealing with, and this is what I need you to help me with. But also with our weight, with our overeating or eating the wrong foods, or making sure that if we are dealing with something like hypertension or diabetes or whatever these other underlying diseases are, that we need to make sure we're taking care. When Katrina hit, so many people did not have insulin. They didn't have their medication. And a lot of that is because we never think that something like this would happen. With COVID, I'm sure too many of us did not think that this virus could also affect me because I have diabetes. So I'm going to stop, and I want to allow time for anyone else who wants to share. I know we have some young people on the line as well, and may be able to speak to this last question about education for minorities, and how do you feel that should work towards you or for your family? Okay, Dr. Butler, who does not want to be seen, she's passing me notes. But one of the things she says, she wanted me to revisit the prenatal care. She says it's important before and after birth. From the cradle to the grave. She said from the cradle to the grave. It's important. Can you guys hear her? You can speak. They can hear you.
When our children in that nourishing stage, as our children are even in the womb, there needs to be quality care. The same quality care that you would get at a hospital that would cater to someone with money or that has that insurance. And so it is very important. Someone put that question forward as to how our Black children come up, how our Hispanic children come up, children of color, how they come up in that prenatal. Is that medicine is very important. That hospital care is very important. And so we should be offered the same chance, same opportunity, same nutrition, all of that, just not the medicine, but nutrition and all kind of quality care for our children to grow up. They need a chance to grow up before they're born. And then after they're born, even into elementary, high school, and then into college. And then have that mindset. Of course, education is very important, but without you feeling well, without you doing well, how can you make it? And if you don't have the nutrition, some of these homes don't have the food that they should have. And so therefore the body is not going to be well.
Lisa, like I said in some of the discussion, is that it's a generational curse, and we have to break that. And whether it be somebody else coming from the outside, that person that's coming from the outside saying, I know how to do it, are you taking a stance? When I was a nursing instructor, my first job was for CNAs. And they would always tell me, Miss Regina, how am I going to make it to school? How am I going to do this? How am I going to do that? I said, I did it. Okay, just like Lisa, I was on welfare. I did it. But when they look at me, they don't see that at first, because they see me as, now I'm an instructor. So one of the things we can do is be that person, that example to them. It don't care what race you are. My mentor for me getting my master's program took me to the side one day and said, you need to be a leader. You need to go back to school. I didn't want to, because I felt like I wasn't going to make no more money. $1 more wasn't going to help me. But thank God I listened. But when I looked at her, she was my mentor. She was the person, that was doing it. And she wasn't African American, but she was a nurse, and she was a nurse leader. So we need to take that opportunity. All of us can be a leader and help someone else.
Well, we are coming close to we are coming to the end of our time. We do want to thank Regina for joining us today. We thank everyone else for being a part of the conversation, this discussion. And I know that it's been informative for me. These past few discussions all have been very informative. I want to give it over into the hands of Linda Dove, who is the brainchild behind these discussions, and have her have some final words.
Regina, thank you so much for leading us in this discussion. I think it was incredibly valuable. Thank you all for coming. I appreciate it. Ruben, did you want to say anything as a follow-up?
I thought it was a great session, Regina. Thanks very much again. And I guess I was just thinking that, in so many ways we're moving in the wrong direction on these issues. We have a government, part of it, that's actively trying to destroy any kind of medical safety net that we have had for a relatively short time. I'm thinking about all the kids, who are out of school right now, who depended on the food that is available to them in school. And so I think this discussion is so incredibly timely. So thank you.
Yeah, I think particularly the way that it interfaces with COVID situation that's going on right now. We didn't really, I don't know. I have Black friends who just, their attitude towards the vaccine, which of course doesn't exist yet, but their attitude is, there's no way that I'm lining up for that, and that's incredibly warranted given the bias that's in the system. But it's a sort of a stark reminder to me, because my attitude is, I am first in line. If I have the opportunity, there I am. And it just throws into real relief the difference, I think, between the way that I access the healthcare system and the way that they do, or their experiences within it. So anyway, thank you so much. Thank you to everyone who came. I appreciate it. Clap. And we're doing this again in 2 weeks. So 2 weeks from today is August 6th. So we will have another discussion on board in 2 weeks. And that's the day after Rachel's birthday, right, Rachel?
Yes, the day after my birthday.
Oh, we will sing to you or something. Anyway, thank you again, Regina. We appreciate it. And thank you all for coming.